So without further ado, I would like to introduce our panel. Sitting right here on my left is Dr. Paul Rosenau. He is a pediatrician. I have to read this because I can't remember everything that they have. It's a long list. He's a pediatrician at the University of Vermont Children's Hospital. He's an associate professor of pediatrics at the University of Vermont College of Medicine and a pediatric hospitalist at the Children's Hospital. Paul served as the first UVM-CH Director for Quality from 2009 through 2014, a period that coincided with the initial 5 years of the hospital's electronic health record. Since 2012, he has served as a physician informaticist for the University of Vermont Medical Center, providing clinical guidance for software upgrades and enhancements. Directly to his left is Mary Evanofski. She's the Director of Population Health Management, Clinical and Operational Process Design at Dartmouth-Hitchcock Medical Center. Mary started her career in the 80s as an occupational therapist. She became interested in policy and traveled the country as a national speaker. Mary holds a master's degree from the School of Public Health at the Dartmouth Institute for Health Policy and Research. She was the Director of Ambulatory Operations at Dartmouth-Hitchcock Medical Center, and I have to admit here, I worked for her, overseeing the resources and processes involved in scheduling, registration, the patient portal, and referral management. In January 2015, Mary transitioned to a very new role at Dartmouth-Hitchcock as Director, Population Health Management, Clinical and Operational Design. To her left is Dr. Mark Burke, Medical Director, Population Health and Accountable Care at Brattleboro Memorial Hospital. He's a fellow of the American College of Cardiology and is board certified in internal medicine and cardiovascular disease. Mark is a member of the VITL Provider Advisory Committee, a member of the One Care Vermont Clinical Advisory Board, and a member of the Green Mountain Care Board Population Health Work Group. In addition to his medical pursuits, I found this interesting, Mark is a founder and a board member at Music New England, a nonprofit music production company. So, little known fact maybe about him. So again, jot down your questions and we're going to get started. I am Kristina Choquette. I am the VP of Operations here at VITL. And so just to get things going, I'm going to ask our panel a few questions. They're prepared, or they should be prepared, because I sent them these questions ahead of time. So in order to start out, what I'd like to ask you is, just a very simple question of how has data really transformed the delivery of care within your organizations? And maybe we can start with you, Paul.
When we're asked to speak, thank you, tell a data story, I knew that really often we're thinking about data for its secondary use to measure something about the performance of a healthcare process or an outcome. But what I realized was something I spent a lot of time over that 5-year span, for example, in our implementation of our health record, was actually that data to really use our EHR was an operational issue. That, if we've ever had any concerns with the usability of our electronic health records or the functionality that they offer, it's often a human-computer interaction design issue, but quite often it is a data problem. And this is often the semantic value of data, whether it's actually information and that information, the context of the data is preserved in different settings, and whether the system is aware of the meaning intended in one place of data capture and another place where it's used, even within the same system. Now, semantic interoperability is really the question at hand, and we first came across this with babies and their head circumferences, and a nurse would measure it, document it, and then the doctor would look and can find it, and of course, there were, ultimately many, many hours of searching later, 3 different data fields called head circumference, some of which presented themselves in one report and some in the other. But that brought my attention really to data as an operational part, that if we want these tools to even work for clinical ends, we have to think about the semantic relevance and be involved. And looking under the hood, it wasn't always obvious. So I was going to tell this little story here of the search for doctor-baby dyads, another topic. So what's a mother-baby dyad is what we call when a mother's had a baby, and we still think of them as partners in their own biology there. So the doctor-baby dyad is a bit of a pun in the land of non-interoperability. Because here's the question. We have a problem. Baby is born. Who's taking care of the baby is the question. Somebody. Who? And I want a name. And then I want a role for that name. And in fact, there are 3 roles. There's going to be a primary care provider. There's going to be an attending who's responsible for the care right now. And for historical purposes, there's an admitting attending who's really just the first attending in potentially a succession of attendings. I just introduced 3 different roles, which is a semantic concept, which may or may not exist and didn't exist reliably in our EHR, and it turns out it wasn't just our EHR. So we had a problem. When I walked into a nursery and I took a survey of, is this person listed taking care of this patient actually the person listed taking care of the patient? And I did this for a while. And initially, this attending, an important person, under 40% of the time, baby's born, we're accurately describing who the doctor is or the nurse practitioner. That's not really high reliability kind of rates. And in fact, what it does is you sets you up for at least 3 issues, 4 if you want to talk about headaches and inefficiencies, but 3 really big no-nos. One is patient safety. So if it's not clear who's taking care of the patient, it may be that no one's taking care of the patient. And that's not a hypothetical concern. Privacy, because we're going to be listing a PCP to go with that patient, we will now fax a discharge summary to that incorrect PCP automatically every time. And thirdly, we've lost every opportunity we might have had at using clinical decision support that's tailored to the right person, who actually is taking care of that patient, if we wanted to actually harness the power of an EHR. So big missed opportunities, and these are not really great rates at dealing with that. So started the journey, and I drew a picture. And this picture is meant to just intimidate everybody, because that's what it did to me. But it's actually a picture I drew when I was trying to understand this notion here of the problem. And it turns out the people process technology model of health information technology was not well understood by me at the time, especially the data side. And I'm only going to just dwell on this to point out a couple things, because I had a couple assumptions before pulling back the curtain. One was the orders. We actually wrote admission orders for newborns. And we listed the attending and the admitting attending. And in the obstetric record, nurses were documenting who the intended primary care provider would be. So those would be our inputs. Well, it turns out the obstetric records didn't go anywhere. It just was a flow sheet that was not actually visible to anybody but obstetric nurses. And the order to admit to this attending with this admitting attending went somewhere, but no one read it, and it turns out it wouldn't have mattered where it went, because that's not the system that had an interface with our electronic health record. See, the only points worth calling out here is between birthing center and registration up top. Those 3 back and forth lines with a few side lines are phone calls, and these are workarounds to what would be the ostensible data flow. And this is, I'm a unit secretary or a nurse calling registration to say, baby's going to be born. And they say, great, we'll start an MRN. Another call, oh, they're not going home, they're going to have a baby here. And there's a back and forth, and in those conversations, somebody using a different, the ADT, the Admission Discharge Transfer Database, would take note of what the conversation was. And later, despite orders or despite any kind of documentation, that interface would, in a unidirectional manner, overwrite whatever had been populated potentially. So that was the ghost in the machine part. So I just wanted to introduce that in solving this problem, we had to discover there are different parts and pieces, different data sources, different messages, and they're different actors. And a couple characteristics of this ecosystem. You'll note that there's no one in charge, right? It's not a self-aware system. There is no one no single entity that understands all the data sources, because they're not the business owners of all of them. They're maintaining their own information for their own purposes. There's no single person that understands the messages, nor the downstream implications of inaccurate data. So here's what we did. Yeah, right. Well, we just threw a wand, we used our wand, and we ultimately added another layer, and I'll just tie up sort of the lesson learned as I breeze through this. So we created recognizing that we couldn't do it within the system, we had a Google sort of single search engine that we designed, additional software for registration. And you could put we added decision support, so you put my name in, and you'll see I show up as an ineligible provider. I'm not a PCP, I'm a hospitalist. Well, that information was known to many, many people, but nowhere informatically as discrete data within the system as a non-PCP. I could have been non-PCP. I mean, you look at my credentials, I'm a general pediatrician, I'm employed by the provider group. Like, nothing here is yet saying I'm not a PCP. So we had to add a layer of information to be used as knowledge. So medical director, query, who also in practice, Dr. McIntosh, what if we put her in? Well, here I can sort of get some guidance that she might be a PCP. In fact, she is. And look, a service that I happen to be participating on, this is a real screenshot of a prior version here, would show up in that. These are the attending zones. So we had the software design. We tried to use the principle that to have any kind of data integrity, where, to use the earlier terms, data needs to be accurate, available, reliable, and complete. We knew that we had to add some sweeten the deal and get close to the workflow. So some providers really wanted to know when they had a new patient under their care. They weren't patients, now they are. Here's an email. And this helped with enrolling practices in their schedules to have this value added. And then we need to have, at the same time, data quality measures, so automated emails out to schedulers of those practices when there were gaps or omissions in the schedules. So what happened with this new software, I'll tell you that we did baseline work to show there were 18 to 25 errors, not just little errors, but errors of provider attribution that were big enough that it was the wrong service being indicated by the naming. So by service, I should also get the term, semantically speaking, clear. A group of providers who are interchangeable but for a schedule to provide a type of care. I might not be on call, my partner is, we're on the same service, that's the idea. So 18 to 25, we put in the software, it dropped down about in half. We saw some different improvements, and just to get through some of the suspense, what happened next? What happened next is we need VITL, but I'll get to that in the next slide. We stalled out, and the reason, if you look at the bottom line, invalid provider and service switching errors. So it became the case that future improvements were that people who never could have been allowed to be providers of a newborn are the most common error type now, either the obstetrician or someone who is going to be the primary care provider far away. So we did focus on the couple principles, which is, and this is wrapping it up, the bottlenecks, making the decision support live adjacent to the workflow. These are key, but ultimately we've hit sort of a ceiling as far as improvement, and that has to do with the provider table itself that we're going to need to really come up with a globally standardized way to describe providers. I'm going to hint at some of the solutions in terms of standards that moving through the integrating the healthcare enterprise has some standards-based offerings for provider directories. We heard, for those who went to the fire talk, there's a few different ways that we might need a federated, distributed system that recognizes there are these providers, but providers have roles, and roles tend not to be captured in current data structures. And groupings of providers as functional discrete data elements, which have members of individuals, don't tend to be represented. And I'm here to say that if we had them, we could really match the baby to the doctor. All right, that's a story.
I hear a very subtle suggestion for a provider directory in that request. It was really subtle, Paul. Yeah, and the ability to break out the discrete provider fields and maybe provide information on it. Correct? Okay, I got it. I got it. Right now, yep. In process, if that helps you out. Great. So now I'd also like to ask Mary if you also have some workflow or how data changed and any happy accidents maybe that that came out of any of the work with data.
Right. So I'm from Dartmouth Hitchcock Medical Center, and when I began to ponder the question, how has data transformed your organization, I thought to myself, well, actually our organization is 123 years old, and data has been used for studies and research for all those 100 years, right? And so then I thought maybe the question really is, how has technology transformed the way we use data so that we can have faster change to healthcare? Because really in those 100 years, it took about 20 years from bench to practice change, right? About 25 years ago, we had Dr. Wenberg and Elliot Fisher and even Dr. Weinstein, our president now, began to think about research and Dartmouth and the Dartmouth Atlas, and began to gather, and they had a peek into CMS claims data for the first time. That first time it became publicly accessed, and then suddenly the Dartmouth Atlas began to look at geographical variation. And so that began to transform medicine a little bit. So 10 years later, we were Dartmouth Hitchcock participated as one of the first practice demonstration projects in Washington, D.C., and it was a precursor to ACOs and Pioneer, and we began to use and look at data a little bit different. So that was a point of transformation there. So then 5 years later, after that, we got a more powerful clinical record in Epic, and we could pull more things out. And we began to think about who else would share their claims with us, because we were finding that getting the Medicare claims was very powerful. So if we could talk with other people and get more claims, we could look at more people. So over the next 4 years, we now have 250,000 covered lives in which we're looking at claims data for all 100. It's actually, my boss would say it's 275 now, Mary. 275,000, we get all of their claims in. But even at that macro level, we still have the attribution problem. I mean, it follows you all the way up. But we're looking at those 270,000 people, and we're looking at their claims across. So now I can look at an opportunity scan. I can say, oh, where are we spending so much money? Well, we're spending so much money on MRIs. Does it surprise anybody? We needed a rocket scientist in a study to do this, but we did. And so we began to think, and we began to work with our physicians. We saw blood products. One of our pathologists, Dr. Mark Servinsky, said, oh man, look at how much blood products we've been using. And he began to take a look at pathology reports and looking at pathology utilization, and he began to think a lot, about 2 years ago, he began to think a lot about what you really need when you're taking a blood sample. And so he began little by little talking to other practices, figuring out best practice, and over the course of 2 years, he saved $2 million in the reduction of blood products. So that sounds pretty good, right? But on a day-to-day, person-to-person, that means what he did was he figured out where in the system we were taking blood when we didn't need to. You don't really need to take blood the first 2 days after a certain kind of medication, because it doesn't really change any levels until the third day. And so he eliminated some of the order sets that got blood taken every single day. And mind you, at the end of it, there was an order that says, take blood every single morning, but it never ends. Like there was never, but stop after the third day. So we took those out of the order set. So we began digging into it. And what it meant for us, right, is less lab tests and like who does like to get stuck, right? And who likes to give blood, and more safety. So everything was better with this just one example of the use of technology in the beginning to root out some of the causes of high expense and not using evidence-based care. So we're seeing that transformation now that we're getting all of the information, but it's still very manual. It's still very people sitting and spending 8 hours of their day trying to like match up the claims. And we've got lots of data. We've got lots of data sitting in files, and we got to get specialized people to like pull those out, attribute them, get them all matched, and we just need to do that faster and faster, because I think that, and I think it's happening, and it's very exciting, but we're challenged by it.
Yeah.
So, yep, that's how we're using technology.
Thank you. Dr. Burke, Mark.
Thank you. I am really fascinated by different perspectives
Yes, I
here
know.
because I'm coming at this from a very different angle.
Yeah.
First, from a very small hospital in a rural community, semi-rural community. And when I read the question, I had similar to you. The first thought was, what do you mean by transformation? In my mind, the connotation I assign to transformation is you're here and then suddenly you're here. It's the big change. We're not there. We're on the way there. We're just sort of beginning to think about maybe we're moving. And then the other question I always think about when these questions are asked is, well, what do you mean by data? Do you mean names that follow you around, that attach to the right people? Or do you mean evidence-based medicine? And if you mean that, what do you mean by that? I was really fascinated by the Watson talk today because I, as a clinical cardiologist, my main work is to deal with individuals and to deliver the large data to the small individual person. And those individuals walk into my office with socioeconomic history and psychology and fears and understandings and expectations. And they want me to give them the best guidance. And when I'm giving them the big data is describing the average person. It's large data sets that have been averaged with confidence intervals. And the person sitting in front of me isn't that person, probably. So what I do is I take the big data, I take their story, and I paint the picture for them. This is the art of what I do. So the data for me is much fuzzier than what people like to think of it as. People like lasers and they like computers, which make it sound very discrete, and it's really, really indiscrete, which is a problem with the Watson stuff, because we're talking about very soft, fuzzy data. Because when we study humans, we can't stop them and do a controlled experiment on them. So, at the level of the individual, it's still art. It's still noise. When you step back, though, in my other hats that I wear in population health, if you look at populations and you say, this population has too much diabetes, let's focus resources on the population. And if we move that population, we've done something real. We can measure reduction in diabetes, but we deliver that at the individual level, at the noise level, at the art level, which is what I'm doing day to day. And I find it kind of humbling, and I also really like the fuzzy edges, so it's good for suits my personality well. So the transformation, I don't think there's been huge transformations. There's clearly been changes. We have the overhead of an EHR, and we have more staff, and we have more clerical duties foisted on people who shouldn't be doing clerical duties, including the nurses staff and the providers and whoever else is involved. But we also we can now move the dial. We can shift populations, or we're at least beginning to learn how to do that. We're at the very beginning of moving frequent flyers from the ED, out. And most of that actually is dealing with the base of the CDC pyramid, the psychosocial stuff. The real changes will come there. If you follow the logic of where our models are going, the capitated model. Capitated model, if you just keep thinking about it, each step of the way, where do you go? You go further and further away from the hospital and the clinic and right into the community and into the bedroom. That's where you go. And so our real interventions are going to be at that level. They're going to be the psychosocial level. They're going to be the policy level. And we don't know how to capture that data at all. We have no idea what's important. We don't even know what to measure. And so the transformation for me is a long way off. The process is part of the fun.
So actually, I'm gonna change it up. I think I'm gonna ask you my last question now, because you've sort of led us there, Mark. If you had a magic wand, This is honestly my favorite question to ask people. If you had a magic wand, how would you use it to either fix an issue or push something into that next realm that you're talking about to really achieve transformation? So I think I'm going to stick with you, Mark, to answer that question first, and we'll move to your right.
Good question. And the immediate response I have is I love, in spite of what I just said, I love data. I love diving into data. I can play with data all day long. I love spreadsheets and graphs and charts. So what I would want is I would want all the data so that I could then play with it and figure out what's really going on and where I need to direct resources. But when I think about that, I think, oh my God, but I don't want everybody else to have all my data. So, but that would be what I would want. I would want the socioeconomic data, the epidemiologic data, the claims data. I would like it all. I would like it all live, real time, and presented to me in a meaningful way that allowed me to identify problems as they crop up and allows me to address them. Mm-hmm. And as I said, you know, that's the medical model. But we're moving away from the medical model towards this more socioeconomic model. So I don't actually know what I would want in that scenario. I have to think about that some more.
Did I stump you? Is that possible?
No, 'cause there's no answer.
There is no answer. There's no right answer. There's no wrong answer. Great, thank you. Mary?
So I, too, think, I think about it from both ends, and one of the things that I forgot to talk about was that patient-level data, and that's where we've been finding as much as we can about people's social history, their functional status, their family history, all of those things, and we're using a lot of patient-reported measures and patient-generated data to find more about that, but we've never really exploited the claims and the finance and the clinical data and the medical social history. We haven't pulled that together, so I'm really like, that's one of my things with the magic wand that I like to do, is pull all of that information together. That, like, how can I put the patient story in with all the rest of the mix so that I can really transform and do something different. So that's my magic wand. But I have a couple more of the magic wand, right? Yeah. So one, sure. I would like to, one of Dave's songs, like I'd like one of Dave's songs just to start singing every time a physician comes and complains to me about data and it's not fast enough. I want one of those songs. And then lastly, I was in a meeting the other day and we were looking at some great data, and we were looking at it, and I was with like 6 or 7 different physicians who are all informatics physicians with lots of interests and ideas and thinking of how things can look differently, and I brought them this data, and it was inadequate. Not that they didn't love it, but they had 8 more questions, and I would like that data. I would like all the data that you want, but I want it now. Like, I want it as fast as my phone can work. I want it as fast as I can think of it. I want to be able to filter on it, but I don't want to see what I don't want to see. I don't want it to be identified when it doesn't have to be. I don't want it to. I want the security and the privacy to work as smoothly as well. That's all.
Paul?
Actually echo many of the same themes. It would be really satisfying, though, to take that wand. Was it wand?
It's whatever you want it to be, Paul.
I'm reading Harry Potter for the 15th time to my children. So, but I'd break the concept of an EHR as the main framework for how we think about health information, because it comes with so much baggage. I think I'd like to use the wand and they become operating systems, what were formerly EHRs, and really pivot the locus of control and organization toward the patient and patient's family, and have it really, really portable and under their control, such that technically seeing a lot more of the middleware software that tries to address a clinical problem, a workflow that then in a standards-based fashion intersects with these operating systems, health data operating systems that which were formerly back in the old days called electronic health records, and they wouldn't let you do anything. So really, I think that I hope we're moving towards being able to engage the health profession in socioeconomic determinants of disease, and I hope we're moving clinical informatics or health informatics towards a patient-centered model in terms of what technologies are there that can follow patients and then transition clinicians more into the coach model and the population health manager. I'm not sure what if I get another wand. I should have wished for more wishes.
You have one more wand if you want.
That's true. I'll hold on to it just for a minute. But
okay. Okay. So I'm going to ask you a question that I did not prepare you for, but it popped into my head while you were all speaking. How about the data from the patient? So the patient actually providing you information either through a survey or through, just sending you information through a patient portal. How do you view that data, and what would you like to see with it being used in your organization? Whoever wants to answer first, I'm going to let you fight that one out.
Okay. So one of the things I love about the triple aim is it's improved care for the population, for the individual, reduced cost, which means you apply population level data, which has to be then delivered at a very granular level, one person at a time, by me in my office, or you when you were in OT, or you in the pediatrics playground. The playground. So the patient data. I mean, so this is, for me, this is a loaded question because this is what I do every day, all day long. I'm a clinician. I take patient data in, including walking in the room and looking, which is about 95% of what I do. Or I've made 95% of my decision by the time I've walked through the door. So I'm not, in some sense, I don't really know what to do with your question because that's what I think I already do. If you're asking about it on a formal basis, so we have a heart failure clinic, and part of that heart failure clinic is we get telemetry data. So we get people send us their blood pressure and their weights and their oxygen saturation and their heart rate, and we get subjective symptoms from them, which we can put on a scale, and then we can then measure and intervene when the data point to an individual falling off the cliff in terms of developing heart failure. So I guess I don't really know where to go with your question completely, since I think maybe I'm too close to it.
Yeah, no, that's okay. I mean, you basically say you use patient data every single day. And so that's your perspective. That's
it includes the socioeconomic stuff. I mean, the 95% of the skill of being a doctor is done when you walk through the door. 98% of the work is identifying barriers.
right.
Why don't you do what I think you should do? Why don't you want to?
That's a
What
whole other topic.
Well,
we
but
could
those
have.
are the critical pieces
Right.
to delivering care. I mean, the heart failure clinic has been exceedingly successful, not because I tell people to do the right things, but because I have a nurse who calls up and makes sure that people understand, and it's the soft touch that's worked. So,
Very true.
so we've taken the telemetry data, which is in some sense hard data, and delivered it in a very soft way to the patient at the other end of the phone line. It's been very, very effective.
Right. I know Paul wants to jump right in, I can tell.
Telemetry is a great example because that's actually a de facto standard as far as having waveforms, and then, but there can also be discrete interpretations of the telemetry results, which maybe isn't standardized. And the question is that captured by one system as something the patient said? Well, maybe telemetry is not an example for pivoting on this, but say patient weight. Mm-hmm. Continuum Health Alliance has standards for scale, it profiles how you get that data into an operating system or an electronic health record. But we're not there in any way, shape, or form because we tend to say that was something that is contaminated. It doesn't have the same validity, perhaps, because it came from an external source. We actually shouldn't presume that. Who's more invested in their weight than the patient? Then, I'm not sure that our, as skilled as our medical assistants or whomever's taking the weight tends to be in a practice, I don't know that it's actually gone head-to-head in terms of studying the validity of data captured from these different sources. So we have an intrinsic bias with our current information systems against patient data, generated data, whether it's quantitative or qualitative. I would love to see us study it first, because I don't think that's a good bias. And we can't use it. That's the thing, is it gets, again, the same head circumference idea. If I need to follow the body mass index, it's more work to develop the strategies for following body mass index if the data points are scattered and encoded as different things semantically. So a weight is a weight, unless you can prove it isn't.
Mary?
So I've been working on, it was called patient-reported measures, and then it was called patient-reported outcomes and measures, and now it's called patient-generated health data. But I've been working on it's kind of my occupational therapy background, is because I am intrinsically interested and think most of the time the patient knows more about themselves than lots of the tests and things that are technically more valid, right? So I've really been working hard with a lot of doctors, and I think one of my best stories is we have been asking the PHQ-9 questions. It's actually 2 questions, PHQ-2, and then it goes to 9 if there's some alerting to there's some problems, and it's measuring depression. And when we've been using that, we've been using it in the primary care setting for a long time, but we just began to bring it into the specialties, and we brought it into OBGYN first. And I remember talking to it, and it's a huge, right? It's a huge workflow process. It gets in the way of stuff. We have some tablets in the waiting rooms, but it's kind of better if they do it at home beforehand. And there's all kinds of workflow things about it. But I said, you know what? It's usually just 2 questions. We can do this. It's just 2 questions. So I said, why don't we just work? I was working with one doctor, and I said, why don't we just take 1 clinic on 1 day, and I'll come up and we'll do it. And in the 8 patients that she saw that day, somebody triggered the next 7 questions, and the person was very, very depressed. And Michelle said, Dr. Luria said, I would not have caught that. I definitely wouldn't have. Usually she thinks her skills are really good, but sometimes people answer those PHQ-9s when they won't tell the physician that. So I'm really a believer in how do we get that information and match it up. That's what I was just saying, is that patient-generated health data has to come up in its status, and I get my claims and my utilization and my clinical information and my patient data, and that would be my ideal system. Good,
great, thank you. So I'm going to stop being selfish, and I'm going to open up the Q&A for people in the audience. If you would raise your hand, and Y and I, or Mary, I see you in the back of the room if you want to help out. Someone has a question. Yes, okay.
I'm wondering about going with the theme that, Mark, you mentioned, we're moving away from the medical model, moving towards socioeconomic model. I would say we're actually moving towards a patient-centered model. And I'm wondering how you would capture what we're looking at now, which is what the patient values. This is really difficult to capture electronically, but so important in identifying what's important to the patient, and most importantly, compliance with the treatment recommendations.
So I think that's an excellent question, and I think the answer I had to that, I said before, is I don't think we know how to do that yet. This is like mental health inventories. PHQ-2 is an excellent inventory, and it's a very simple test to administer. But I think that's where we need to direct a lot of resources to answer exactly that question, because we don't know. I don't even think we know what the right questions are to ask, what data to gather, even if we knew how to gather the data. I mean, I'm endlessly fascinated in that question, and I've struggled with ways to try and figure it out, and I'm not sure. It's a great question.
So at Dartmouth, we have a Center for Shared Decision Making, and it's only just a sliver, but it starts to get at, for some conditions, it starts to get at asking questions about risk, value, benefit, what do you want to do? And we have that integrated into the medical record. But again, it's not always set side by side, and we don't always, we're not always following it. The same with honoring care decisions. We have advanced care planning and advanced directives, which we all know are very important. But we've had some physicians do some studies, and it looks like about 40% of the time do we really honor that care decision. So how do we not only capture that but actually honor it? So I think it's a dilemma that we've got to get to the bottom of, I think.
Yeah, I would go further. We need to develop processes to, in a continuous fashion, with a continuous relationship, keep it at the center in terms of what are the values and the priorities. When I think about, and it has an informatics supports that all around it, but the relationship in the conversation is key, that coaching idea. So it's strange, and if you look at what our information systems do currently for, say, a child and their family on the outpatient setting, and then they come in the hospital. So they're allowed one chief complaint. You get one. Your chief complaint. We're going to write it down, and if it, that's it, because that's your chief complaint. And it's insane. But what really a lot is built around that. In fact, I will not get paid if I don't reiterate every single day what the chief complaint. I'll probably get paid either way, but the hospital will. And so obviously we've structured things around billing systems. But here's a process that would try to get at some of your question. So we have family-centered rounds at the Children's Hospital here. Rounds is not a singular event. It takes preparation around meeting planning, and formally, we meet with families before the meeting as a pre-meeting to set a shared agenda. To say, we're going to have a meeting with your care team, and you're part of that. What should we talk about? And that's different than the medical model traditionally of we're going to shove someone to the front and present at you, even if we do it in your presence, But in fact, we're going to jointly decide what it is we even talk about. And yet, our electronic health record doesn't support that workflow even, even that's not even a concept in it. So we actually, ironically, work on paper, which is a very nice medium. It's smooth, and it folds nicely. And we have whiteboards, but it's that process that I think we then need to really say, well, what was happening there? Can we represent it in a way that's more generalizable and extendable so that it can reach more people and be more meaningful? Because guess what? People don't have, they get stage fright, or they thought of something at 2 a.m. And in having the asynchronous part of the communication in preparing for a shared meeting would be a kind of informatic response to your question of valuing people's values. So,
and I think one of the things that the way we treat data is as a two-dimensional structure, where a data point is a single variable with a single descriptor, and really the human existence is three-dimensional. And I was a programmer in a different life, and I'm very familiar with top-down thinking, which is not how I think as a physician, and not how I think in this kind of venue, where I'm looking at things in a very three-dimensional way. I'm twisting them around. And so the question you're asking is on the other side of the cube that I'm not looking at right now, and I need to learn how to sort of structure, how to allow the electronics or whatever you have to turn it around so I can look at it this way. And we don't, we don't know how to do that yet. And we aren't doing it. Maybe we do know how. People smarter than me know this stuff, but I don't know how to do it, and I haven't seen it done. But I think we need to sort of restructure how we even think about the data as this more organic, complex, non-two-dimensional information container.
Hi, Michael Moschitis from OneCare Vermont. Paul, as someone who's sat in a room with you trying to build a provider directory a few times, I've seen your drawings.
I'll talk to anybody. Like, here I am.
They're great. The projects that are built from the data that each of you describe and stuff, they seem to fit into your individual organization or to the project that is most important to you. But how do you feel, or where's the importance lie and the feasibility and lie in pushing that out to a region or to the entire ACO or something, so other people can track the same things that you're using the data for?
I can put duct tape on my mouth if you want to go. So the last three slides, though they would support the use case of the newborn provider attribution, that's just a use case. And those were actually slides from an interoperability profile. Mm-hmm. So in fact, the whole point of the standardization of which attributes go with a provider, which attributes go with groups of providers, and what's the architecture of that, that's supposed to be generalizable. So hopefully the value proposition is equals as many use cases as you can come up with. And I think of them all the time, as far as we talk about, this whole bit of relationship. I mean, I just brought this up because it is sort of provocative. Why on earth do we don't ever include who did that patient as a patient just interact with? We don't put as much emphasis on this. We assume we know. But I was in the business of trying to infer what groups of providers, what their behaviors are, what they're doing. And there's so much unbelievable overhead in the secondary use of data if we don't get the initial attribution right in the first place. Mm-hmm. So on that, I just wanted to bring that up, even though, yes, it is a sort of selfish interest. I think the point is, in a way, to really respect who did that patient interact with is still sort of patient-centered. It's like that's portable, but we don't track it, so we can't even tell them who you interacted with today. Because on your after-visit summary, it's going to say who was assigned a bit haphazardly. Mm-hmm. So I think there are many use cases as far as decision support.
So I think along with attribution, the other thing is just the integrity of the data. So actually my job is I'm a director of population health management, clinical and operational design. My job is to make whatever is good design be in all of the places and take it out to our ACOs. And it's the integrity, it's that transferability, and it's that the definitions have to be the same along the way, and that's the hard data part. And then there's the soft part, which is the workflows and the teams and how I've always done it. So there's like two sides to that question: is how do I get the data and make it look the same and make sense to everybody, and then how do I actually change my practice and people want to change the practice, that they're excited about doing it, and that it makes their practice better and not more cumbersome but better.
Mm-hmm. One other thing about standards, the whole point of us having standards is not to be interoperable, it's to lower the economic price of that implementation. It's so that at each iteration of a similar solution, you don't have to reinvent the wheel, and overall it expands markets and keeps costs down. So the value of the standard is actually through multiple use case iterations.
Mark, anything to add, or? No?
I'm just thinking about what you just said, Paul, and I was kind of interested in that because when we standardize things, we lose information, and it's the information loss that I think, I wonder how much of that marginal loss is important in the end. I was thinking specifically about Watson and the natural language abilities.
Well, can I counter one thing? I think you have a risk of losing information, absolutely, but you do it so explicitly. Because if you're really adherent or conform to a standard in terms of any given data field, if that data field conforms to a standard vocabulary, at least it has a definition. Right now, the semantic issue is we're not sure how much your ostensible, blood pressure is the same as this one, is the same as this one, if we're talking about quantitative data. So perhaps you're at least being explicit about what you're claiming a certain meaning to be when you use a standard vocabulary.
So I guess I wasn't disputing the need for it, at least in the current state. I'm just sort of thinking beyond that, wondering, well, there's really actually information out there that's being lost when we do that.
Oh yeah.
And we might do a much better job by not losing that data or that information.
Yeah, I think it's been clear what you know up to what point, or which part is standardized and which part isn't.
Yeah.
Because right now we don't keep track of which is which.
Yeah.
It's actually interesting that you say that, because we are building a data warehouse in the VHI, and we've been struggling with that as well. We want all the data, and we want to be able to define the data, have it be structured, and we kind of go into this esoteric, if you can imagine programmers being esoteric at all. We go into this whole realm of, but we don't want to lose anything. We don't want to lose the pieces that are not structured because they mean something. So I think it seems that everybody is grappling with this when they talk about data, and it's kind of good to know that you guys grapple with it as well. So I think we have about 5 more minutes or so. If I think you had a question, so it's going to be the lightning round answer, because we do only have about 5 minutes.
I guess I have more of a comment, because I'm working in a small hospital with ACO reporting. And one of the things that I find over and over again is that we fail to create meaningful reports when we don't involve every single person in the system who's gathering information. So, for instance, like blood pressure screening. So it was novel that referrals weren't meaningful if they weren't attached to diagnosis. Mm-hmm. So it was like, well, we're measuring referrals. I'm like, well, they're only meaningful if they're attached to a diagnosis of elevated blood pressure in the absence of hypertension. It doesn't mean anything if you just get the referral. And it was like, oh, interesting. And so you have to start, it's like, especially in small situations where you don't have sophisticated informaticists, you really have to sit down with the nurses and the providers and the informaticists, and everyone needs to be collaborating, create meaningful data, because otherwise you're just creating data that has no purpose.
Right.
So I feel like I'm knee deep in that.
I'm sure you have comments to that one. I know I do. Okay, well then I guess I'll start. So I was just in a meeting where we were talking about data and process and reporting, and we were trying to determine whether or not we were, kind of doing pretty poorly or just in the talking about it stage, or if, it was best practice, or if it was just really being utilized broadly. And we started talking about data and this workflow, and we said, actually, it gets to the point where you say, oh, it's being used broadly, and everybody seems to, have this process in place, but is it a good process, and is it really meaningful, or are we just doing process and data just for the purpose of being, doing it? And so, yeah, I understand the fear where you do have to step back and actually look at it from, an outsider's perspective. So, any comments? No?
Go ahead. Go. All right. Our recent past decade with implementations and justification for information systems often is around non-clinical pairing of information. Oh, it turns out you need to have these data elements together to qualify for X, Y, or Z. That's really true for a lot of quality measures,
right,
actually, because when they are nationalized and adopted by a standard body or National Quality Foundation, whatever, it has to be feasible by a broad swath of people, which means you get enough people, it doesn't really tell you much, because if everybody can do it, we're probably good on that one already. So, you know, it's the challenge of incentivizing measurement with this much heterogeneity as far as information systems. You end up incentivizing things that everyone can do, and therefore it doesn't mean anything.
Right.
And, you know, just this is a little bit tangential, but if you step back, because you talked about the ACO, the reason we have quality measures on the ACO is not because we're trying to measure quality. The history of that was to make sure we weren't cheating.
Well, there you go. It's a different purpose. Yeah.
Right. So, which is why most people find the measures not too helpful, and you know, so the context was completely wrong. And it wasn't, the aim was not to measure quality. If we really decided to measure quality, we probably would have done it very, very differently.
All quality is local, and then it has to bubble up. I mean,
Exactly.
That's how change has to be too. In fact, data has information in the context of the users of that data, right? Workflows, et cetera. We strip down all data sets every time we send it somewhere, because we can't ship the context with it. So we actually have to over-specify to have any semblance of information attached to it by the time it lands there.
So, well, I'd like to thank the panel. It's exactly an hour, and I hope you got some great information. I know I did, and I'd love to get the three of them in the room together with me and start helping us maybe rethink how we do things. So again, thank you to our panel, and thank you for attending.